Good morning again. We're going to start our first joint community and policy session, and it's my pleasure to introduce Patricia Doykos from the BMS Foundation. Patty.
Thank you, Bill. Good morning, everyone. Good morning. So I'm Patricia Doykos. I'm director of the Bristol-Myers Squibb Foundation, and it's my pleasure to moderate this first panel. Before I get started, I did want to thank Gary Puckrine, Congresswoman Christensen, and the National Minority Equality Forum for giving us the opportunity to come and share some of the things that our grantees are learning through our Together on Diabetes program. And I also want to thank Jim Gavin, who really was the one that encouraged us to come here and share this. The panel is entitled Strategies and Policy Recommendations for Creating an Equitable Response to the Type 2 Diabetes Epidemic. And this title really reflects the aim of the Together on Diabetes program of the Bristol-Myers Squibb Foundation. Can I have the slides, please? So our foundation's mission is to promote health equity and to improve health outcomes of populations disproportionately affected by serious diseases and conditions. It started out as a $100 million initiative for the U.S. in November of 2010, and we had the opportunity to expand to China and India this last May. And our focal points for funding and partnership are really things that happen outside of the clinic, but that patients absolutely need to manage chronic diseases like diabetes. So the first part is patient self-management and care navigation, and we're really challenging our partners to think about diabetes as a long disease journey. So what are the supports for education and navigation of care that are needed over a very long disease journey? Then the second part is integrated community supportive services and broad-based mobilization. So what are the healthy eating, active living supports that patients need outside of the clinic? And also, how can communities be mobilized to really fight diabetes, to understand that there's an opportunity to address diabetes, that it is a community effort, that things happening in the home, in social networks, in broader community organizations are absolutely critical to the response. It is too big for just the medical system to address on its own. And the last component of this is providing an innovation sandbox where really new ideas can be brought to bear, not only from other disease areas, but also other community development efforts. What can we learn from promised neighborhoods? What can we learn from recycling? What can we learn from major efforts that are impacting many communities and many settings that people move in and out of in the course of the day, so that the healthy choice can be an easy choice for the person living with diabetes? Disparities really comes down to prevalence, access to quality care, and outcomes. And this is some of the information that we have from the CDC about disparities regarding prevalence. So the general population is 8.3%, and then you see different numbers for other segments of our populations. Our seniors, those over 65, 27% are burdened with diabetes. African American population, 18.7%, and you see that this goes on. And we heard earlier that it's not only about minority populations, it's also regional groups. And we see that in Appalachia, particularly in economically distressed communities, the rate is at 13.1%. With respect to access to core diabetes services, and this is just a tiny slice of the access and quality care issue. This is from the National Healthcare Diabetes Disparities Report. It says that the proportion of people ages 40 to 46 diagnosed with diabetes who access the 4 annual services, so hemoglobin A1C tests, eye exams, foot exams, and flu shots, these are all recommended by the ADA, that it was significantly lower for poor and middle-income individuals, non-Hispanic blacks, and those without at least some college education compared to their respective comparison groups. And then on the final point, it's outcomes, the morbidity and mortality, the suffering as a consequence of diabetes. Here again, just a few snapshots. For kidney disease, Hispanic and Latino populations are 2 times as likely to develop kidney disease as the general population. For amputations, African Americans are 2.7 times as likely. And finally, with respect to death, American Indians and Alaska Natives are 1.9 times as likely to die from diabetes. And we really need to change this picture. So before I go on, I just wanted to quickly introduce all of our speakers. They will tell you more about their organizations in the interest in time, but they will be presenting in this order. Kim Prendergast from Feeding America, Ben Bluml from the American Pharmacists Association Foundation, Dr. Donovan Beckett from the Williamson Health and Wellness Center in West Virginia, Nadia Ali from the Camden Citywide Diabetes Collaborative, and I know many of you have heard about the good work of Camden. And then finally, Robert Greenwald from Harvard Law School. So you'll hear about 4 projects, implementers working with these strategies to really turn the tide on diabetes. And then we also wanted Harvard to help us begin to think about what are the enabling policies that would need to be put in place in order to sustain what works, to keep it going, to expand it and scale it, and through that work, bend the curve on diabetes. So I would ask that in the interest of time that we hold questions to the end, and that will also give us an opportunity for all of the panel members to participate in the Q&A. So thank you, and I'll turn the floor over to Kim.
Good morning. Thank you very much, Patty. My name is Kim Prendergast, and I am here on behalf of Feeding America, which is the largest domestic hunger relief organization in the United States. We are in every county, in every state in the United States, with a network of over 200 member food banks and all of their agencies who are providing access to food for millions of Americans. How do I work this? 1 in 6 people, that's 50 million Americans, are living in a food insecure household. And that is not just hunger, but people who don't have the ability to afford foods for a healthy diet. So the kinds of foods that we would like for them to be eating because we're hoping to prevent chronic disease or to manage chronic disease. And 1 in 5 children are affected by food insecure households. For Latino and African American households, they're more than twice as likely to be food insecure as their white non-Hispanic counterparts. And approximately 1 in 3 children in Latino and African American households are living with food insecurity. So we know that this is a big issue for all of us to be considering as we think about the social context for chronic disease and for health disparities. And I appreciated that Dr. Gibbons set us off on that right note to really be thinking about all of the things that play into individuals' health. For individuals who live with food insecurity, they're more likely to experience chronic disease, especially diabetes, and that's from the NHANES data. For those who have diabetes, those who are food insecure have worse glycemic control than those with ready access to healthy foods, and other health outcomes they struggle with as well. More than 1/3 of clients who rely on the emergency food system report having to choose between food and other basic necessities like medical care. Every 3 years, Feeding America does the largest study of food insecurity and the emergency food system called Hunger in America. And we've found lots and lots of data that show that people who are relying on the emergency food network report chronic disease in their household, report being in poor health, and report that they have to make choices every day. Do I get the medication that my doctor prescribed for me, or do I feed my children? And these are many of the factors that lead to the health disparities that we're dealing with. When we think specifically about food insecurity and diabetes, it's a cycle. Families are living with food insecurity. They're making decisions every day about how to spend the dollars that they have for food and for other necessities, which becomes a cycle of food adequacy and inadequacy. They get their paycheck, they get their SNAP, their food stamp benefits. They can eat better. Towards the end of the month, Towards the end of the month, it gets worse. When I was a dietitian at the Brigham and Women's Hospital on the dialysis unit, I talked to a patient about how often do you eat 3 meals a day? Oh, the first 2 weeks of the month. Are there days of the month that you don't eat at all? Absolutely, my children come first, despite the fact that he had chronic kidney disease and went on to have dialysis and multiple transplants. So it's a cycle of poor diabetes control, which leads to poor health, increased healthcare costs, and the worsening competing demands of health, of decisions about which bills to pay and how to feed their families, which continues the cycle. So the Feeding America Diabetes Initiative is an opportunity to break that cycle and to really think about how food banks and how improving food access can increase that. And so we're really, really grateful to Patty and to the Bristol Myers Squibb Foundation for recognizing these issues as they invest in diabetes work and for giving us the opportunity to investigate the link between food and diabetes. So this is a 3-year project with Feeding America and 3 of our member food banks with the goal of creating bi-directional collaborations between food banks and their community healthcare partners. And we chose food banks in 3 communities around the country that look really different to get a sense of how this would work in different geographic areas and different kinds of settings. So the Corpus Christi Food Bank is a suburban food bank in Corpus Christi, Texas, where diabetes and obesity are huge problems. The Mid-Ohio Food Bank, while Columbus, Ohio isn't a huge city, it's a much more urban area where they're working. And then the Redwood Empire Food Bank in Santa Rosa is dealing with a very rural population and migrant workers and individuals who are really hard to reach because of their geographic dispersion. And the goal of these projects is to identify food insecure clients who are living with type 2 diabetes and connect them with appropriate food for their condition, to provide them with nutrition and health education in a culturally relevant and way and in a language that works for them. And then if they don't have a physician, to connect them with a medical home and to help them access the medications and the blood sugar monitoring supplies that they need. We're working closely with Hilary Seligman at the UC San Francisco Center for Vulnerable Populations to evaluate this project. There's a pretty intensive pre and post survey that clients go through when they enroll in this project so that we can really look at not only the changes in hemoglobin A1C and blood sugar control, but also other effects of the intervention, including the effect on depression and diabetes distress and self-efficacy, and really looking at, by giving folks the access to food that they need, are they eating better, are their families eating better, and have we really made a difference? So to date, this is a 3-year project that started in September of 2010. So we're about halfway through our 3 years. And we're finding that diabetes is very, very common in the food bank setting. So far, we've screened about 1,500 clients. And as of our data analysis, we had 767 had confirmed diabetes and or hemoglobin A1C of 6.5. And as of our data from last Friday, we're nearly 1,000 clients enrolled and 921 so far. So we've had great response. Diabetes is very common, unfortunately. And it was really one of the shocking things that we found. We thought that we would identify a lot of undiagnosed diabetes in this population. These are individuals who are coming to a food pantry, a food distribution site, and we thought that we'd find lots of individuals that didn't know that they had diabetes. So far, 95% of the individuals that have enrolled in this project had already been told by a doctor that they had type 2 diabetes. Yet we're finding that their health is very poor. The mean body mass index is 34.5. Their diet quality is poor when we look at fruit and vegetable consumption. 62%, nearly 2/3 of the clients are consuming 1 or fewer servings of fruits and vegetables a day. Less than 2% consume the 5 fruits and vegetables a day that would be recommended. So while they know they have diabetes and they've been told to manage their condition, they're not able to do that. The higher the rates of food insecurity, so we're looking at we're using the USDA food security screening questionnaire as part of this, and the higher rates of food insecurity, those with very low food security or those who are the most hungry, have the worst health status to begin with. Poor glycemic control, the baseline hemoglobin A1C is 8. Higher rates of depression, greater diabetes distress, greater medication non-adherence, and more food medicine trade-offs. And these are the people that you're seeing already because they know that they have diabetes. During the project, the clients are receiving boxes of food, getting whole grains, lean proteins, low-fat dairy products, and fresh fruits and vegetables. They're getting recipes and tips for using the foods that are in the boxes, as well as nutrition and health education, both through classes, through one-on-one education, and through lots of resources that are being sent home, both in English and Spanish, depending on the language spoken by the clients and their families. Clients who don't have access to a doctor, medication, or their blood sugar testing supplies are getting referrals. And then likewise, the food bank staff are working with their community health center partners to educate them on the problem of food insecurity so that those clinicians can identify diabetes clients who need access and make referrals into the food bank so that all individuals in the communities have access to the food that they need. So preliminary results, we just have a small sample so far that we're looking at, but we've done lots of discussions with clients through some surveys and focus groups to get a sense of, do they like the food? Is this helping? And they definitely feel like their diabetes is in better control because of the food provided. They're feeling supported. They're excited to try new foods. They're excited about getting a diabetes-friendly food box, and being able to take charge of their disease and manage their health in a way that they haven't been able to before. And it's turning out that with our small sample so far, that this is showing some outcomes. We have significant decreases in hemoglobin A1C levels, in depression, and it looks like diabetes distress is trending that way as well. So supporting individuals in this way is making a difference. Some key lessons and findings that I want to share with you that you can begin to think about in your own practices. Awareness of diabetes is there, but glycemic control is poor, suggesting that our current self-management support and access for food for a healthy diet aren't adequate. The food banks that are throughout the country are trusted community organizations that clients visit on a regular basis, and they're playing an important role in chronic disease self-management. So our healthcare system can't do it alone if we know that the individuals in our communities don't have access to the supports that they need. So think about your community organizations and your food banks as an opportunity to really address the health status of your clients. Developing food bank and health center partnerships and educating clinic staff about available resources is critical as we support chronic disease self-management for low-income communities. So thank you very much for your time today.
Good morning, everyone. I'm Ben Bluml. I'm a pharmacist by training. I'm with the American Pharmacists Association Foundation and from America's Pharmacists Home on the Mall between 22nd and 23rd on Constitution. I bring you our greetings. So I'd like to tell a story this morning about the work that we're doing as a partner in the Together on Diabetes initiative. I'd like to first acknowledge the BMS Foundation and Patty and her team for all of the wonderful support because the work that we're doing just simply would not be possible without their vision, their support, and the extraordinary opportunity to be a part of this initiative. So let me start by talking about the high-level objectives of our project, which is called Project Impact Diabetes. And the acronym IMPACT stands for Improving America's Communities Together. Our focus here was to take the successful models from the Asheville Project, from the Patient Self-Management Program for Diabetes, and from the Diabetes 10-City Challenge that had worked so well with self-insured employers through an evolving evidence base from 1 to 5 to 10 different communities in the country, and to really scale that up and to spread that out and to focus in a new way on these disproportionate share populations and really try to implement a model that includes collaborative care with pharmacists, that includes a continuous quality improvement process, that has a patient self-management credentialing approach that I'll talk about in a few minutes, and that actually also insists on some accountability through collection of minimum data sets. This project and program is implemented in 25 different communities around the country, a variety of diverse types of settings. We have pharmacists who are collaborating with other healthcare providers in community pharmacies, employer work sites, federally qualified health centers, free clinics, homeless clinics, and county health departments in 17 different states across the country. Just a handful of examples to give you some context about the type of care and the type of environments that this care is being delivered in. One of our communities is Paramount Farms in Lost Hills, California, who's serving farm workers in conjunction with community pharmacists and an on-site clinic. We have Variety Care, a federally qualified health center in Oklahoma City, serving uninsured and underinsured populations of urban and minority patients. We have free clinics in Richmond, Virginia, like the Daily Planet and Crossover Ministries, serving patients who are homeless. We have a clinic in Eau Claire, South Carolina, where a cooperative healthcare center, including internal medicine and pharmacy collaborators that serve large rural populations, is participating. And the University of Mississippi Diabetes Care Group, in conjunction with pharmacists from the School of Pharmacy, focused on needs in patients with the Department of Health in Jackson, Mississippi. As we implement these programs, we create a structure and process model that helps people to understand where the goal lines are and where the out-of-bounds markers are at, but we really expect people to call their own plays on the field, if you will. So in each of their local communities, they're charged with making these processes their own and implementing a variety of sustainable types of activities that really apply to their populations of patients. The goal is for these care activities to be focused on the patient, putting the patients first, to be supported by pharmacists, and to be interdisciplinary in nature. In our resources, we provide communities with an online knowledge base, with a patient self-management credential that I'll talk about in more detail in just a few minutes. A few of these communities have EMRs and electronic health records in place that allow them to collect data. For those that don't, we provide support through databases that are able to transmit this data on a quarterly basis, and for us to receive the minimum data sets so that we can understand the impact. And then we have technical advisory services through a variety of mechanisms, through community coordinators and an 800 line that are available in each of these sites. One of the unique elements in each one of the programs that has proceeded in this history since the Asheville project has been this patient self-management credential. So you might ask, what is this credential? This credential is a tool that's really designed to create some standardization in the experience that the patient receives, regardless of the community where these programs are being implemented. It has 3 different domains. It has a domain for knowledge, it has a domain for skills, and it has a domain for performance. And in each one of these domains, patients work together with their community pharmacist to advance their knowledge base, their skill set, and ultimately their ability to be an effective self-manager of this chronic disease. The program and the assessments are designed to actually meet people where they are, to help the healthcare providers who are collaborating and working with these patients understand where their knowledge strengths are, where their knowledge weaknesses are, and to really help them to make the best use of the resources that are available to help them to advance their ability to effectively self-manage their condition. When we look at the type of collaboration that's going on in these 25 communities across the country, pharmacists are working with a variety of different types of providers: primary care physicians, endocrinologists, cardiologists, nurse practitioners, dietitians. Students are often involved in many of these communities, obviously certified diabetes educators and the diabetes education centers where they're available in these communities, interacting with community health workers, in some cases promotoras, and then a focus in collaborating productively with dentistry, with podiatry, and with ophthalmology to effectively move the agenda along as it relates to caring for these patients and addressing the critical needs that they have. In terms of the settings that these are happening from, I talked about this a few moments ago, but essentially you have pharmacists in community pharmacies and employer work sites, federally qualified health centers, free clinics, homeless clinics, county health departments, and et cetera. But I want to take a moment to also just help everybody in the room to think about a really important statistic when you think about pharmacy. Pharmacy and pharmacists are one of the most dramatically underutilized resources in our healthcare delivery system thus far, we believe. If you take recent data that was published by Walgreens and you look at the number of visits through the front doors of a community pharmacy in this country, there are a little over 301 million people who pass through the doors of community pharmacies each week in this country. So when you're thinking about points of access and ways to collaborate in the healthcare delivery system to actually get more care to people who need it the most, we think that it's a really important idea to make sure that you've got the pharmacist engaged as an integral member of that healthcare delivery team. And the results are showing that it works. We have consistent measurement in place in these programs with the self-management assessments that I described. We have minimum data sets that are reported, and we also have qualitative data collection efforts that are going on. In June, we'll be releasing We'll be launching a media campaign that will talk about these different experiences in these 25 different communities. There'll be video montages that describe the experiences at baseline as these communities were getting started, as well as 12 months into the project, to help people understand the context and to hopefully inspire and rally people in communities that are like these all across the country to be interested in implementing this type of a program. This slide's a bit busy, but these are the interim results from our project, and the data says that we're seeing statistically significant improvements in blood sugar control, in systolic blood pressures, in LDL cholesterols, in BMI, and we're seeing a very effective pattern of empowering patients to be more effective and more in control of their condition. And the evidence and the information from our patient self-management credential supports that. So these are just a couple of quotes that I want to leave you with here this morning. This is from a physician who's collaborating with her pharmacist in Richmond, Virginia. She's talking about wanting this forever, thinking about sustainability because the patients are excited, the staff members are excited, and she thinks this is a dream team for diabetes. When she came up, a pharmacist was a pharmacist and a physician was a physician. You didn't work together. Now we're bringing up a new generation of healthcare providers so they can learn to co-manage patients together. And this is a really interesting model where in this clinic, the physician and the pharmacist are actually visiting with the patients together as a team to help to move them along in their understanding and in their ability to be an effective self-manager. And finally, and most importantly, a perspective from a Native American patient. Adrienne says, and sure enough, I'm cutting my weight, my blood sugar's in control, and I'm feeling more energized. It's like I'm 18 or 19 years old again. When I walk out of the pharmacist's office, I come out of there with confidence. I get the confidence that I can do it, and it shows because I'm doing it now. He's doing it, he's having improved lifestyle changes, better diet, exercise. He's engaging in his blood sugar monitoring. He's getting his foot exams, eye exams, and he's sticking with the medications that have been prescribed for him by his physician. So at any rate, I really appreciate this opportunity to share this information with you about our project, and I'll turn it over to our next speaker.
Hello, my name is Dr. Donovan Beckett. I'm a primary care physician in Williamson, West Virginia, Mingo County. And I'm going to kind of give you an overview of our community struggles with diabetes and our strategies to overcome that. West Virginia is fourth in the nation in the incident rate of diabetes. Mingo County is second in the state of West Virginia, and we have a rate of 10.9%. Nationwide, that percent is 9.3%. Mingo County is the second unhealthiest county in the state of West Virginia, and 1 out of 8 adults in Mingo County have been diagnosed with type 2 diabetes, and that doesn't include the undiagnosed. What we've been able to do in Mingo County is create a collaborative coalition centered around the Williamson Health and Wellness Center and the Diabetes Coalition. What we've been able to do is take educational tools and resources out to the rural parts of the county by utilizing Together on Diabetes and support from a foundation like Bristol-Myers Squibb. We've been able to create programs that are making an impact with our community. The Lunch Walk program we started 2 years ago. And this program was an idea between two people in our coalition of how to create some competition between community members to get them exercising and walking. So basically what happens is you have members on a team, 10 members on each team, and what they do is they wear pedometers and they calculate their steps and report this to a team leader. That leader then reports it to our coordinator. And when we first started doing this program, we're like, you know, we're gonna walk the state of West Virginia and show how impressive that is. Well, before the second week was up, we were out of West Virginia, so we got to go somewhere else now. So we set our sights on Los Angeles, and we did have 2 of the 10 teams successfully had gone to Los Angeles. So we were very excited and happy about how that had gone over. This year we have 30 teams of 10 members each. And we're proud to announce our sister clinic in Marin City, California. They have taken our model and adopted it, and they're now doing a lunch walk program. But they're going to be walking to Williamson, West Virginia, and our clinic is going to be our lunch walk program is going to be going to Marin City, California. So it's a program that's we're utilizing in schools, and it's been adapted now in other parts of the nation. So we're very happy about the success of that. A lot of the programs that we've utilized are well known, such as Dining with Diabetes. This program is a 4-week in duration, and it's able to teach diabetic education. You also have cooking demonstrations on proper ways to make your meals. A lot of people aren't able to put together how they should make meals properly, so this kind of breaks it down for them. They have demonstrations, they're able to do that. We measure pre and post hemoglobin A1Cs with this program, and we've been able to show that there's been significant improvement in people who participate in this, and then we measure that at no cost to them through the foundation. Our Walk with Ease program has been a very successful program that targets our elderly. This program has been a huge success in that it's centered in a lot of senior centers and churches throughout the county, and it encourages physical activity with our elderly. I think our oldest participant, I think she's in this photo here, she's 93 years old, and let me tell you, she waits on no one. When this program starts, you better be there. She's going to leave you in her dust. But it's been an exciting program to get our seniors out and moving around. A big problem in Mingo County, it's a very rural county, and we have trouble with access to healthy foods. We have one grocery store in the entire county, and that's on the eastern part of the county. So the middle part of the state and the middle part of the county and the western part of the county have to rely on fast foods or convenience stores to get their nutrition, which is a big problem. So what we decided to do was create a farmer's market. And we started out with the market being a monthly market, and it was greatly attended. We had lots of positive feedback. So the next year we started to do it on a weekly basis. This market last year had a gross profit of $37,000, so it's been very successful as well. What we were able to do with that was then to go into our next project, which was a community garden. Our community garden, as you can see, has 2 high tunnels, which are basically kind of greenhouse-type structures that allow us to extend our growing season and then also encourage more farmers to utilize our services and get more producers in the market. We also have 24 raised beds that you can see there as well. What we've been able to do with that is not only are we encouraging consumption of healthy foods, but we're also trying to create entrepreneurship to where people can grow, and whatever they don't consume or give away, they can take to our market and sell. We've also had the opportunity to acquire the county orchard. This was put on a post-mine land use site, which we were told that post-mine land use sites are non-viable. There's nothing that can grow there, so it's just a waste of time and effort. Well, if you go there today, we have an orchard that's full of apples, pears, grapes, and berries growing abundantly. The problem is picking it all. So we had to come up with a program to get to be able to help us get those and get them to the market. So what we created was a pick your own day. And 2 days a month, we allow local residents to come up and they get a pick from the orchard. And what we do is at the end of the collection, they're able to keep half of that, and the other half they give to the market, and we take that and sell that to help sustain our market and move through with that. These sites have not only been great to encourage the use of local foods, but it's also been great educational sites. We've had workshops here on permaculture, on how to construct your own greenhouse at home, and plant propagation, so it's been an educational source as well. The statistically biggest success that we've had is with our diabetes education clinic. This is a 2-day class. It consists of 4 hours, and you're instructed in self-management by a certified nutritionist and a diabetic educator. Since we've started this program, we've had over 400 participants go through, and every year we've had from 1.7 to 2.1% reduction in hemoglobin A1C. That's astonishing, because what we do is we utilize all the efforts of the farmers market, the other programs that we've involved, such as the lunch walk program, plus this diabetes education center. And to reduce an A1C by 2.1%, I'm going to show you statistically how that plays out. From that, we can reduce, if you drop your A1C 2.1%, you're going to get a reduction in amputations by 90%, You're going to reduction in renal failure by 50%. You're going to get reduction in myocardial infarction by 29% and strokes by 25%. So that's how important it is. I mean, if this were a drug, we'd be rushing to market with it right now. So it's very impressive to see how we're able to lower those things by using all these efforts of the community. Our next project is we're going to be we are participating with the Centers for Disease Control and Prevention and the Appalachian Regional Commission through a grant from CMS. And what we're able to do with that is take all these educational tools and resources and then bring them to the more rural parts of the county to help with making behavioral changes in their thought process on diabetes. So we're trying to make that impact and measure that as well. So, Mingo County is a small county, but we've been very effective because of our ability to use this collaborative spirit and then also efficiently use our resources. We want to continue to be a county that is a hub for health and wellness and sets the example of creating programs that can be replicated throughout other neighboring counties and then the nation and world as well. Thank you.
Good morning, everyone. So happy to be sharing with all of you today. Just to provide you with some background, I'm with the Camden Coalition of Healthcare Providers, and we are a citywide, data-driven, nonprofit healthcare coalition. We have a membership organization with a diverse set of stakeholders receiving hospital and foundation support. We are about 11 years old, with approximately 50 staff, and our mission is to improve the health status of all Camden residents by increasing the capacity, quality, and access of care in the city while reducing costs. And what you see in front of you is our theory of change model. Data, engagement, and clinical redesign are the three primary elements we believe it will take to drastically improve the healthcare delivery system here in Camden. So, moving on to the why we're doing this work. The prevalence of type 2 diabetes among adults in Camden is 12.8%, nearly 50% higher than the state average. Through our population-level analysis of hospitals' claims data, we found that costs are concentrated in a disproportionately small number of patients. 1% of patients in Camden account for 30% of the costs. And analysis over a 6-year period identified 6,711 patients living with diabetes in Camden, accounting for 24,000 hospital and ED visits, with total charges amounting to $854 million. Patients with diabetes are twice as likely to go to the ED compared to patients without diabetes, and those patients are 2.5 times as likely to be admitted to the hospital. So, the need for programming to address this target population has been really crucial. Through our work with the Bristol-Myers Squibb Foundation's Together on Diabetes initiative, we've begun to improve diabetes care at the patient, provider, and community level. Some of our strategies include building capacity at the primary care level through care coordination and quality improvement efforts. We've embedded nurse-led multidisciplinary care teams, which are pictured on the bottom left. We have a RN who supervises 2 LPN care coordinators, AmeriCorps health coaches, and we also have a program assistant on staff who are sort of our feet on the streets, boots on the ground people. And we're also leading quality improvement efforts at the practice level around building diabetes registries, clinical protocols, and provider and staff education. We've established free diabetes self-management education classes throughout the city across 3 sites, 2 of which are in Spanish, and they're led by certified diabetes educators alongside peer supports. And to your top right, there is Jackie, one of our community health workers, who is from a small neighborhood in Camden called Fairview Village, and she actively reminds patients to come to class and gently nudges them to attend free fitness classes. So she's been a tremendous support to our diabetes education programming. We also hold group diabetes visits across 2 primary care practices. And to your top left, you'll see one of our provider champions in the center at one of our inaugural group visits. And we also have educational support groups across 2 practices in the city. And really what we're finding is developing a support system has been instrumental in building community and reducing stigmas around diabetes. We've been able to build this capacity and improve access and empower patients to take better control of their health. So what we're finding so far is really some positive results around reduction in A1Cs, hospital utilization, and greater collaboration. In our deeper practice-based work, we've seen tremendous progress with this. With our first cohort of patients, we've seen an A1C reduction in nearly 70% of our patients, and the folks we work closely with have an A1C of 10 or greater. And one of our patients went from an A1C of 11.6 to 6.7 in just 3 months, just by re-engaging her with the physician, just destigmatizing the use of insulin, and connecting her to community supports. With regards to hospital utilization, we've also seen a really big decrease in 30-day readmission specifically. In our first cohort of 11 super utilizer patients, before our intervention, these patients had a total of 13 30-day readmissions, and after we engaged them, we've only had 2 30-day readmissions. So that's been really wonderful to see. And lastly, the quote here in the slide was said by one of our provider champions, and it really embraces the true meaning of team-based care. It reads, quote, "You can't do this yourself. Even as one single family practice office, the tougher your patients, the more help you need. It's not just about extra resources and extra reminders. It's actually learning new ways to help patients better manage their diabetes. I've been learning a lot. It's more than just an extra set of hands." So, when he said this, our team really felt like, okay, he's on board, he gets it. So it's been really wonderful to see the improved linkages and the greater collaboration between nurses, diabetes educators, and primary care providers, really breaking down those silos. Some of, along these major strides, we've also learned some really great lessons and also encountered some challenges. We're finding that targeting the most complex patients can lead to immediate and positive patient outcomes, and relationship building with healthcare providers and patients is key. Focusing on the way things are communicated has helped us to build relationships at both levels. Our patient-level intervention is grounded in motivational interviewing, which is a therapeutic communication technique originally used with people with substance abuse issues, and adopting this method of communication has allowed our teams to be really patient-centered and drive the patient's agenda. Assessing a patient's level of readiness to change really gives us the opportunity to tier our outreach and allocate resources effectively. And while we're working to break down the silos within and across health systems in Camden, it's still very difficult to coordinate care across various settings. One of the things we found is whether it's going to a group visit, attending a diabetes self-management education class, or messaging to the patient that we're from the provider's office has really helped to build relationship and trust with the patient while maintaining a central hub and enhancing the provider's care. So I just want to conclude by saying that the current structure for primary care is really reactive and not proactive. It doesn't always have the structure in place to catch extremely complex patients, which can be one of the factors for patient readmissions. If I come through the doors of a primary care office, I'm healthy, I'm in and out in 15 minutes, and I really think that this 15-minute time slot needs to be re-engineered for someone who has 5 chronic comorbidities, substance abuse issues, and was recently discharged from the hospital and has a lot of barriers around transportation and insurance. These are some of the common characteristics of the majority of our patients who should really receive the red carpet treatment when they're discharged from the hospital so they're comfortable going to their medical home. So really having the external resources like us and having this wonderful opportunity through the Bristol-Myers Squibb Foundation to help facilitate and re-engineer these current processes will really enable practices to be better equipped over time and engage the community across the city. So thank you.
Good morning, everybody. My name is Robert Greenwald. I'm a professor at Harvard Law School and the director of the Law School Center for Health Law and Policy Innovation, which includes its health and its food law and policy programs. And I really feel privileged and honored to be here today and also to be part of this incredible panel of evidence-based projects really trying to promote access to care, treatment, and prevention for diabetes. Let me just quickly, I'm going to try to save some time here because I think it's really important for us to have time for question and answer. So bear with me as I go quickly. Our project is called Providing Access to Healthy Solutions, or PATHS, and it's really a collaborative effort with state-based partners working to develop an overarching health and food law and policy framework for reducing health disparities and barriers to access to care. No, I'm doing something wrong. So at the same time as we do the law and policy work, we're also working with our state partners to build advocacy capacity, coalition development, and really help people bridge the gaps that often take place between community-based work and government work by helping facilitate health reforms on the state level. So in terms of our project PATHS, it's currently taking place in 2 states, North Carolina and New Jersey, and we expect to expand to a 3rd state this summer. And throughout this year, we're working with our state partners, conducting one-on-one interviews, focus groups, to really learn hands-on what's going on in different states. Our commitment is for the project to be bi-directional, so we're interested in hearing from our state partners, people working on the ground, what's going on in their state, but then we also take that information and provide research to try to help develop solutions to the problems that are addressed. So the research that we're doing, for example, is we research laws such as the Affordable Care Act and the Farm Bill. We look at programs such as Medicaid and Medicare, the SNAP program and the WIC program. And then we look at other states to find best practices. And all of that research is trying to find solutions to the barriers to access to care and health disparities that can potentially be solved through law and policy reform. So at the end of this first year of working with our state partners, conducting the information, getting the research, we basically develop a set of recommendations. And then we work to implement those recommendations over the next few years with our state-based partners. This project is actually modeled after a project that we've worked on for the past 5 years in 11 states in the context of HIV and hepatitis. And I see some of our state partners here today that have worked on those projects. And we've worked in Alabama, Mississippi, North South Carolina, Louisiana, Texas, some of the most difficult environments to try to implement health reforms, and have had tremendous success by, again, working together with our state partners and really engaging government in healthcare reforms. So today, since there's not much time, I'm only going to talk about one set of examples of ways that we can move diabetes care, treatment, and prevention forward, and that's looking at the Affordable Care Act. So this slide is up here, and it's kind of a dense slide, but really what I want you to pay attention to is how much of the slide is underlined in red. And basically, all of those provisions that are underlined in red are either optional to states or depend on state regulations in order to be implemented. And so basically the decisions in terms of Medicaid, for example, that all states have to be grappling with, and we've heard about this recurringly from other speakers before me about the Affordable Care Act. There's a question as to whether states are going to expand their Medicaid program. In North Carolina, that would mean 500,000 low-income people getting health care as of January 1st, 2014. There are questions as to whether states will opt in to the Health Home program, which is specifically designed to provide enhanced and coordinated services for individuals with chronic health conditions, such as diabetes. There's optional free preventive services within the Medicaid program that, for example, would mean that every person in Medicaid would get free diabetes screening as just one example of a free preventive services. And then ultimately, it's really up to states to decide what the essential health benefits package is going to be for both Medicaid beneficiaries and people in new subsidized private health insurance plans, and whether those benefit packages truly meet the standard of care for treating diabetes. As to private insurance, there are also tremendous amounts of reforms that are dependent on states, whether outreach and patient navigation programs will truly reach the people that need to be reached in terms of diabetes care, whether the new networks of care, accountable care organizations, for example, will include the providers, the types of providers we've heard today, many of whom are on the cutting edge of trying to create new ways of addressing diabetes prevention and care. And just to say, as we've heard from other speakers, the Affordable Care Act certainly has many challenges to it. One of the biggest challenges is that the federal government has largely given tremendous amounts of flexibility to states. And that's why the state regulations and the options to states are so important. But what that also means is that health disparities will often continue, because instead of having strong national standards, which we still need to push for, we now have to work state by state to make sure that the opportunities that are available through the Affordable Care Act are enacted. So quickly, what I want to really use as an example are my panelists today and talk about the kind of opportunities that are available through the Affordable Care Act, which is the exact work we're doing with our state partners, trying to help them maximize the opportunities that are available through the Affordable Care Act. Now, Kim talked about a very important program, getting food and nutrition services recognized as a critical component of effective medical treatment. The bottom line is, under current rules, most food and nutrition services in most contexts are not reimbursable through insurance, through health insurance or through Medicaid. What Kim is trying to prove is basically food is medicine, that food is a cost-effective way of helping to manage diabetes by giving people access to healthy food. Now, there are new provider networks being created through the Affordable Care Act, and there are very strict requirements about both quality improvements and cost control. As Kim's program moves forward and demonstrates the cost effectiveness of providing people access to healthy food, those health networks need to include programs like Kim's in their bundled payments, in these new systems of reimbursement, and the Affordable Care Act allows that. So it is possible in all states to create food and nutrition programs that will now be reimbursable through the Affordable Care Act. Now, Ben's program, the pharmacy program, very similar in many ways. Pharmacy services also often not covered through Affordable Care Act, through current insurance systems. And that's why they're dependent on programs like the Bristol-Myers Squibb Foundation program. But let's be clear, those kinds of programs and funding, as great as they are, tend to be limited in terms of their time and scope. We need to tap into existing entitlements and funding streams that will be ongoing. So Ben's program, not only can the pharmacists probably demonstrate the cost effectiveness of their program and be part of these accountable care organizations, as I mentioned, there's an optional program in Medicaid called the Chronic Health Home Program, which allows states to provide enhanced and coordinated services for individuals with chronic health conditions. We're working with states to make sure that states opt into this program and make sure it works for people with diabetes. Now, what Ben's program really demonstrates is the critical role that pharmacists can play in terms of case management, care coordination, and that's an essential function as part of these health homes. So as these health homes move forward in states, our work is going to be to ensure that programs like Ben's are included in those chronic health home systems and therefore reimbursed for the services they provide. Now, Dino talked about a program in a very rural part of this country. He talked about the coalition that's been formed in Mingo County and all of the amazing programs that they're doing to get people into healthcare and to feed people. But the main thing that I took from that message is how successful they are at reaching out to people in rural communities. Now, the Affordable Care Act funds what's called patient navigation and outreach services. Particularly will fund patient navigators and outreach workers that can uniquely reach hard-to-reach populations. That's exactly what this coalition is. And so Dino, as just one opportunity, can plug into this reimbursement stream for patient navigation and outreach to help support their efforts to bring people into care and provide them with healthy food. And then finally, you heard of Nadia's Camden Coalition. That coalition is already a chronic health home. It's a health home, not necessarily funded yet through the Affordable Care Act, but should be and will be in the future. But in addition, all of those health and social service providers are essential community providers, many of whom are not currently part of care networks. One of the requirements for private insurance reform is that all new systems sold within the exchanges and marketplaces have to have 20% of their providers be essential community providers. Nadia's program and programs like that currently aren't part of the major care networks need to make sure that the networks are held accountable, because they are required by law now to have 20% of the providers on their network be essential community providers. So just in conclusion, I just want to say we clearly face many challenges. We face many challenges in so many ways in terms of effectively treating diabetes, preventing diabetes. Our food system, which I didn't get to talk about today, supports cheap access to unhealthy food and often fails to promote access to healthy food. This is something that can be solved through law and policy reform. Similarly, the healthcare system currently leaves 50 million people in this country uninsured, and many people that are insured have inadequate health care. The Affordable Care Act and other health law and policy reforms can make a huge difference here. So again, while we have many challenges, we are working with our state partners. We love to work with all of you to really try to reduce barriers to care, address health disparities through law and policy reform. Thank you.
Thank you, everyone. We just have a few minutes for questions. Do we have any questions from the audience? Good morning.
Hi, Renee Jenkins from Howard University. I had a question to Kim about the food bank and its impact on children, because clearly you spoke about the issues that many of the families that you deal with have children, and we know that childhood obesity, which we're going to talk about later, is higher in families who also, the parents already have dietary problems. So are you going to, or have you considered at all what preventive impact you might have on the children in these families?
Great question. Thank you very much. So certainly we know that the diabetes is a family issue and not just affecting the adults in the family. The intervention that we're doing right now is specifically looking at individuals who are over the age of 18 who have diabetes. We are providing foods that we recognize are used by the whole family, and so the surveys that we're doing are asking questions about the number of children in the home, and the post-survey is really looking at what are the changes in not only that adults' eating habits, but the other folks in the family as well. So are the children, and it's broken down by age, I can't tell you the exact one right now, but 2 age brackets of children in the home, and then if those children are eating more as well. Across the Feeding America network, there are a number of programs aimed at children as well, but for this, we're looking at the impact, hoping to prove that by educating the family members, by educating the people who are making the food, and by providing better food to the family, that everyone in the family is lifted up and their health conditions are going to improve.
Thank you for a wonderful and very motivating discussion on this topic. My name is Monina Clevens. I'm at CBC. One of the things that I've seen actually in the lay press, not in a journal, was what the U.S. could learn from Iraq, where, I don't know if everybody remembers that article, but it was reaching out, not waiting for people to come in. And some of the comments are bringing people in to healthcare. This was, in fact, sending maybe people along the lines of promotoras or something like that, where they would go look at a person's kitchen, help them understand what they need to do to be able to control diabetes, and in fact immediately showed a decline in emergency room visits. Can you comment on that?
Just to say, all of those kinds of services are the exact kind of services that can now be funded through a well-implemented chronic health home program, where you literally could go into people's homes and try to address the issues, buy people, steamers, if that helps, or something like that, to try to, in the context of elders, is putting carpeting in people's houses. These can all be reimbursable services now. Again, all of the networks, the way people are getting funded, fee for fee-for-service is over. It's going to be bundled payments. You get a certain amount of money to treat a certain person with whatever health condition, age, and other criteria. And how you spend that money, there's a tremendous amount of flexibility. And the degree, again, to which we can prove that all of these kinds of initiatives are cost-effective will all of a sudden drive the Aetnas of the world to start to fund those kinds of interventions. So that's the good news, and I do think that it's taking lessons learned from other parts of the world that have certainly far better health systems than we have currently.
I would just add to that the opportunity for us to do the Together on Diabetes program and the foundation is built on our work on HIV/AIDS in Africa, which did many of the things that you were talking about in terms of mobilizing communities, looking at communities from a strengths-based approach, and doing the outreach that will serve the community outside of the clinic. Sometimes we talk about it as the 23 and a half hours between appointments that are the most critical. So what is happening during that time, and what are the resources that are immediately around the patient, so their family, their social networks, their community, and how do we strengthen those and engage those, learn from those, ask for solutions from those communities in order to really scale the response that we need here in the country. So, thank you.
Hi, my name is Frank Clark. I'm a third-year general psychiatry resident at the University of South Carolina, and I enjoyed the panel discussion. My question is for Ms. Prendergast regarding your feeding initiative. You mentioned that 767 of your clients had confirmed diabetes, and I know there's a growing body of evidence that suggests that people with depression have an increase of diabetes and vice versa. And I was just curious, how many of your clients actually had pre-existing mental illness?
So the questions that we're asking on our pre-survey are fairly limited in what we're looking at, but we are asking questions. There are 2 questions on depression, and I can talk to you more later about what those are. And what we found is that depression is a huge problem. On average, about 2/3 of the clients who we found with diabetes are answering yes to those questions. So the depression is a big problem in this. And as we stratify by food security status, those who are most affected by food insecurity have the highest rate. So those who have very low food security have 84% of those individuals had depression, which really caused us to stop and think, what else do we need to be doing? Is there more that we can offer? And we've had a lot of conversations about just how well the food banks are feeling like they're connecting their clients when they make referrals to the community health centers and their healthcare partners. If they don't have physicians, are they also getting connected to mental health services? And obviously there's lots of challenges with that in communities as well. The great news is that initial data look that we did just a couple of weeks ago shows we are seeing an improvement in the depression status just with the 6-month intervention. So that's really exciting, and we're going to continue to look at that more. But we recognize that these are all very intertwined, and having the stress and the challenges of access to food, which means you likely have lots of other barriers to success in your life, is certainly a big challenge.
Hi, my name is Farouk Saadatman from Howard University. My question or comment is with Dr. Greenwald about food as medicine. The China study book that has come out, and probably most of us have read it, has clearly indicates the relationship between diet and disease. And not only we can prevent heart disease, diabetes, high blood pressure, almost any kind of disease on a whole food, plant-based diet. How can we make that a really important part of the message that is the cheapest thing, as you said, food as medicine, and it's not just diabetes. Everything else can be prevented and reversed with cheap food almost.
Well, I can give you one example. In Boston, there's a program called Community Servings. It started as the nutrition program for people living with HIV and AIDS and is now diversified to provide nutritious meals for people with chronic health conditions. For years, they have tried to connect with the health insurance networks, and no one's ever called them back or given them the time of day. I was just meeting with them the other day, and they have appointments set up day after day after day with all all of the leading health networks because they get it, that they are going to be getting bundled payments, as I said, capitated rates for serving their population. And they can continue to do it the traditional way they do it, which is high cost, ineffective, or they can start integrating the kinds of things we're talking about. So all of a sudden, they're calling, phone ringing off the hook to say, talk to us about the kinds of food and nutrition services you can provide. Talk to us about how much it will cost to include you in our networks in terms of what we provide people. There's a huge opportunity here, but we have to make the opportunity happen because they don't really know what they're doing. They know that they can save some money. They've read the studies, but they don't know how to get from here to there. We're the ones that have to help them get from here to there. But this is the first time ever in this country that there's funding streams and potential here for us. So I think it is a great opportunity. Thank you.
Thank you so much for the opportunity to share today. We'll be around to talk to you a little bit afterwards as well. And I would just close by saying that public-private partnerships are absolutely key to addressing health disparities. And with that in mind, we have spent $44 million, but we have quite a bit left to get to the $100 million. So we are looking for partners. And just last week, we announced an exciting partnership with Morehouse School of Medicine, who will be our dissemination and implementation partner. One of the things we'll be doing together is identifying 10 communities across the United States where the lessons learned from this initiative, but also other major initiatives in the country, can be packaged together, made relevant in the context of the ACA in terms of pulling down on all the different incentives that are in place and all the opportunities, and really transform communities with respect for diabetes. So look forward to sharing more information about that initiative as we go forward. Thanks again.